We're going to talk some about orthopedics of Prader-Willi syndrome. And actually, I like the title. It was in the book better. What's the orthopedist talking about? I have a lot to talk about, so I'm going to take questions at the end. If there's no time for questions in the room, I'm here for the rest of the afternoon. Just grab me, and I'd be happy to talk to you. But let's get going. So, quick introduction. Now, luckily, Dr. Dewis gave a talk earlier this morning, so a lot of things in these first few slides she's already went over, but Prader-Willi syndrome is the most common genetic obesity syndrome, first described in 1887 with an adolescent girl who had the features of Prader-Willi syndrome. But it was many years later that Prader, Labhart, and Willi actually described their series of patients. They did it all separately, and then poor Labhart as a middle child kind of got left behind. And then it was about 20-some years later, 30 years almost, that they first figured out that it was on chromosome 15, that there was an abnormality there. And it was still several more years before they could figure out the uniparental disomy, because they kept on saying these were chromosomally normal kids with Prader-Willi syndrome. Real quickly, to recap what Dr. Dewis said, because she talked about really well, is Prader-Willi syndrome is on chromosome 15. It is the father's contribution to chromosome 15 that's got an abnormality. You know that we're all made up of 23 chromosomes from mom, 23 from dad, and they come together. And what happens is that there's a problem with dad's chromosome 15. And it can be a deletion, which means there's a piece that was missing from the chromosome. It can be that for some reason there are two chromosome 15s from mom and dad's never made the scene. And then there's this separate thing where you can have what's called a methylation defect. So mom and dad's chromosome 15 are both there, but there's a defect on dad's chromosome 15. And that seems to be the only one where you can have more than one child, or you can expect to have more than one child in the family with Prader-Willi syndrome. But for most of the other cases, it's very uncommon to have more than one child. So what do we see in orthopedics with Prader-Willi syndrome? Well, hypotonia is really the overriding characteristic. Especially in the infants, we have developmental delay, and that hypotonia, that low muscle tone, leads into the scoliosis issues, the hip dysplasia issues, and the flat-footedness. We're going to talk about all those as we go along here. So why doesn't my orthopedist know much about Prader-Willi syndrome? Well, it's a very rare condition. It's about someplace between 1 in 10,000 to 1 in 30,000 births has a child with Prader-Willi syndrome. So in most cases, a pediatric orthopedist might see one or two in their career unless they're in a place where more of these children are drawn in. And you compare that to other things that are rare, but the pediatric orthopedists see regularly. Cerebral palsy is 3 in 1,000. Spina bifida is 7 in 10,000. So these are uncommon things in the general public, but in orthopedics, relatively common. The problem is that you end up getting kind of a generalized thinking. Okay, I don't know Prader-Willi syndrome, but I know similar things. I know Down syndrome. I know cerebral palsy. So I just have to take what I know and kind of mush it around, and it looks like Prader-Willi syndrome. Well, the problem with that is kids with Prader-Willi syndrome follow different orthopedic rules. And so you really have to think of these kids as a child with Prader-Willi syndrome who also has scoliosis or flat-footedness or hip dysplasia, rather than a child with scoliosis who's got this Prader-Willi thing also. Very important, and we're going to keep on emphasizing that as we go along. So with this talk, I want to talk about 5 different topics. Developmental delay, so delay in reaching milestones, flat-footedness, osteopenia, meaning weak bones, hip dysplasia, and then we'll finish up with spine deformities, which is probably the most common thing that people want to know about. But developmental delay, so hypotonia, that low muscle tone happens early on, even before the child is born. Most moms who've had a child with Prader-Willi syndrome say, hey, it wasn't kicking as much as we expected as my previous pregnancies. And that's because the hypotonia, the child is not moving around as much. And oftentimes these children are born post-term, so they're born after dates. And a lot of times they need to be born by cesarean section because they just can't kick themselves out. In the newborn, we see the poor sucking ability, the weak cry, and then as infants and toddlers, they have poor head control and they have poor postural control. If you try to sit them up, they kind of slouch down, kind of like a bag of potatoes. The milestones can take, on average, about twice as long as they would in a typical child. So if a typical child is sitting at 6 months of age, a child with Prader-Willi syndrome can take 12 months. Walking on average can take someplace between 20 and 27 months of age before they're walking, so, which is delayed compared to usually about the first birthday. So what do we do for that? Well, therapy, therapy, therapy. From the very start, we want physical therapy to be working on balance and motor abilities, trying to get them stronger. We use bracing in certain types. When we get the kiddos up close to doing some standing, we want to have some braces that give their ankles some stability, and actually in doing that, we also give their knees a little stability, and that makes them a little bit more daring in terms of letting go of furniture when they're trying to learn how to walk. And for this, we use something called an ankle-foot orthosis, or an AFO. And for, the saying that I use all the time in my clinic is I want to get the kids up walking any way possible and then work on points for style. So I'm not worried about starting a kid off in a brace, especially when they're never going to remember it, because by the time they're walking, they're still pretty young. But if it helps them start walking a few months earlier, well, that's a few months earlier, they're exploring their environment, they're using their hands to do things, and that's what we want to speed up. The whole tough love of they'll get up and walk when they can, I don't like that. I think we need to really help these kiddos. So this is what AFOs look like. I apologize, this is for a larger and older child, but it gives you an idea of what the braces look like. They come up to just below the knees. The ankles I don't want the ankles to move because there's another form called a hinged AFO where the ankles do move. Great for children who have spasticity, whose feet want to kind of push down, such as cerebral palsy. But in Prader-Willi syndrome, they have really weak ankles. So if you put those on, they're just going to collapse to that hinge, and you're not helping them. So we really want to stabilize their ankles. And when we do that, we also stabilize their knees to a certain extent, and that gives them more confidence to be standing upright, that they're not going to collapse down if they stand upright. So the next kind of logical progression to talk about is the flat-footedness. And that's what we're seeing here. If we look at the pictures to the right, you see the line I drew at the bottom of the leg and the line along the heel there. You see how the heel's kind of rolled out to the outside there. And if we also look at the side of the foot, we see that there's kind of an outwards curve to the foot. And this comes because the child it has very lax feet. The ligaments around the foot are very flexible, and they kind of roll into this, and they don't have the right muscle strength to kind of pull their foot up to hold into a good position. And so this is a very common thing. Surveys say that about 40% of children with Prader-Willi syndrome will have flat-footedness. Now, we have to differentiate that. Most typical children will also be kind of flat-footed around this age, but they get stronger. And if you have them stand up on their tippy toes, they'll make a nice arch and they'll roll their heels inwards. And that's what we look at with the Prader-Willi kids. If when we get them up on their tippy toes, their heels are still rolled to the outside, well, we need to help them. We need to support them. So if you fall into pronation, if you fall into a flat foot, your feet are badly positioned for walking, for running. The heels are rolled to the outside the ankles, so you're not building a nice stable construct. You're kind of tipping over. And it's hard to generate a good push-off. When we're walking and you're getting to that point where you're about to push off like this, you need to have a firm support. Your foot actually kind of becomes more rigid so you can step off of it. Well, if you have a flat foot, you're kind of stepping off the inner side of the foot and your foot collapses, and so you actually lose some of your efficiency with walking. And over time, the Achilles tendon then gets shorter because the foot's trying to stabilize itself. It keeps on trying to pull in every muscle it can, and so the Achilles, which is the muscle right behind the ankle, that gets shorter, and it gets a little bit hard to get the foot into a good position. And then the last thing is that if you really have very flat feet, occasionally what will happen is that the knees also are now unstable, and so the child, they will oftentimes walk with a little bit of a crouch gait where they're slightly bent. And in doing that, they also walk with their feet a little bit wider, and they will sometimes keep their hands up in kind of a semi-guarding position so that if they fall, they have their hands ready. So these are some of the positions that you may have recognized in some of the kids you've seen around you. So what's the treatment? The treatment is bracing. We just want to put the foot into a good position that as they continue to grow, that we're molding the foot, hopefully getting everything to line up and get stronger, and with the idea that at a certain point in time, everything's going to gel out in the right position and we can stop bracing them. So there's a couple of different kinds of braces. One is called an SMO, or supramalleolar orthosis. You got the two little ankle bones right above your foot. This one comes right above those little ankle bones, and it's kind of, it has these little ears that come up to kind of hold it in place. It usually doesn't come down the full length of the foot. And this is my bias against the SMOs. And again, this is more of a philosophical bias than anything else, but I'm not a big fan of them because I don't think it really helps to correct that curve to the foot by helping to push it over. And the ears that come up on the side, for them to actually stabilize the foot from side to side, they have to be really snug. Now, if they're really snug, then you can't move the ankle very freely. So the brace that I prefer instead is what's called a UCBL. So here I'm just showing, here's a child who's got flat feet. If you just put a wedge underneath the arch, you're not really correcting what the heel does. What you have to do is actually roll the heel underneath the ankle, and that's what these braces do, the UCBLs. And they come down the whole length of the foot, so that if you're looking at the foot that's got a curve to the side, you see how the braces are made to come down the whole length to kind of help push that over. And so you're molding, you're kind of guiding the direction that the foot is going as they continue to grow. All right, to switch gears now, talk a little bit about bone mineral issues or bone fragility. This seems to be a fairly common issue, hopefully getting less common now that we have so many children on growth hormone. But if we look at the literature, so there was a survey that PWSA-USA did a while ago, and 9% of respondents said that they knew that their loved one had bone fragility issues. But then there were other surveys that were done on adults. So a British survey said that 29% of adults that they looked at had a history of a fracture. And one of the points they made is that people with Prader-Willi syndrome, because they have a higher pain threshold, oftentimes there was a delay in making the diagnosis of a fracture. And then there was a Philadelphia study where they actually took x-rays of everybody, and they found that 45% of adults had a history of a fracture. So it can be relatively high. Again, hopefully we've been doing better in the last decade or so, but we haven't really been to be able to look at that recently. Back in 2004, a study came out that showed that people with Prader-Willi syndrome had a 20% decrease in bone mineral density, so that they had about 1/5 less bone strength than we all have. And that's primarily in the lower back spine, the lumbar spine, in the pelvis, and in the legs. Whereas in this study, it said that the head, the skull, the arms, and the upper spine seem to be pretty well preserved. So what can you do about this? Well, the easy things, the growth hormone, which pretty much all our kids are on, but also supplementing with vitamin D and calcium. Most of our kids are seeing endocrinologists, so you can always get some input from endocrinologists. The way I look at vitamin D is it's hard to overdose on vitamin D. Most of us, we as adults and our kids, even the typical ones, are low on vitamin D, and that's one of the big things that the orthopedic community is getting very worried about. So it seems to be a good thing for all of us to supplement on, and if you're going to do that, also supplement on calcium. And keep kids as active as possible. The more that you're stimulating the bone, the more you're driving calcium into the bone. If they're not very active, then they're not going to get much calcium into the bone. And then the last point is awareness, that we realize that they do have a higher risk for fracture and that they have a higher pain sensitivity. So if you have children that are limping or they're not using one of their arms, that you have a high suspicion that there could be an issue that needs an x-ray to be able to diagnose. And I've known of kids who've worked on tibia fractures for a short week before they finally got diagnosed. So it's one of those things to always think about. And also in terms of surgery, that the surgeon is aware that the bones may not be the same strength as they'd expect for a child that age. Now let's move over into hip dysplasia. So on your left is what a typical hip looks like. On your right is an adult with Prader-Willi syndrome who's got hip dysplasia. And the differences are how much the socket covers over the ball. So in a typical hip, you have a good ceiling of a good roof of the socket over the ball, whereas when you have hip dysplasia, more of the ball is kind of uncovered. And then the easy way to think about it is when you don't have as much coverage, the ball can slide back and forth, the cartilage doesn't stand up to that very well, and it starts to deteriorate, and you can get arthritis. And also at the bottom here, hang on, through the wonder of, there we go. So at the bottom here, you see these little arrows here. This also shows how the ball is kind of sliding to the outside in the socket, where in this socket is pretty good. Well, the news is that actually it's not all that bad in Prader-Willi syndrome. So first of all, talk a little bit more about hip dysplasia. Dysplasia means the abnormal development or growth, and presumably this was actually very normal in the very beginning. So way back in early pregnancy, when you're first starting to take a solid block of cartilage and divide a line between the socket and the ball, that is the most normal it ever looked. And then what happens during pregnancy, where typical babies are kicking around, they're helping to drive that ball deeper into the socket, whereas our babies with Prader-Willi syndrome, they're not kicking around as much, and the ball kind of drifts out a little bit. And what's actually happening is you're missing some of that maturation of the socket. And so it can kind of deform a little bit over time, and you actually need not only the movement of the ball, but the muscles working across that joint to help that develop nicely. Now, there is always a concern about hips that are out of socket. I only know of a small handful of kids in my whole Prader-Willi practice that were born with the hip out of socket. There are other places that have written more on this where they have seen more of this. But I think it's still a pretty low risk issue. The bigger issue is really the hip dysplasia. And depending upon which articles you read, that risk is someplace, or that incidence is someplace between 8% of kids and 30% of kids. And that's compared to about 1% of typically developing children who will have hip dysplasia. Part of that, when you're looking at that 8 and that 30, you go, boy, that's a pretty wide span. Part of that is when they're actually looking at the kids with Prader-Willi syndrome. So that 30% was when they were looking at fairly newborn children. And that 8% is when you're looking at them when they're somewhat older. And that I'll be able to explain that a little bit more in a second. So what you want to do is, first of all, prevention. We want to screen the hips to make sure that they're okay. In my book, I want a good clinical screen. I want somebody to really have a good feel of the hips like we typically do with any baby to make sure that the hips are feeling that they're stable in joint and they're not popping out of joint or not out of joint to start off with. If they are, then you got to take care of that. You got to get the hip in the joint. But if the hip otherwise feels pretty stable on examination, I don't want to worry about that hip until the child is somewhat older. So I want the child to be as active as possible so we get those muscles working across the hip joint and try to get that to stimulate the development of the hip. And then when the child is old enough for me to get my first spine x-rays, which we'll talk about in a second, but it's about when they're starting to do some sitting. That's why I also want to get the hip x-rays to see what the hips look like and make my diagnosis of hip dysplasia at that time. Now that's probably that is different from what we do with typical children, probably different from what a lot of other practitioners say to do with the Prader-Willi kids. But that's because if you diagnose hip dysplasia in a very young child, not dislocation, but just dysplasia, what people want to do is put them into the typical things that we do. It's a harness or some other brace that will put the hip deep inside the socket and hold it there. Well, the problem with that is we want our babies with Prader-Willi syndrome to move as much as possible, even if it's just a little bit. You put them into that harness, and they're just going to be happy not to move at all. And that, I think, is a disservice. So that's why I don't want them in the brace. The other thing is that the brace is trying to put them into a position like this, so the hip out to the side. Well, if you think about most of our Prader-Willi syndrome kids, if you put them in their crib on their back, they kind of go into that position, what we call the frog-leg position. So they're putting their hip into the right position anyway. So I would rather not brace them. I want them to be as active as possible and just continue to follow up on them. What about that concern about hip arthritis? Well, like we were saying, if you don't catch hip dysplasia and that hip joint doesn't develop well, then over time, usually 40s, 50s, 60s, that cartilage starts to wear down and you need to talk about replacing a hip. So that's kind of the end point of hip arthritis, is a hip replacement. So we said, well, let's take a look and see how many hip replacements there are in Prader-Willi syndrome. There are no articles on that. So what you do instead is you go to these big databases that we have these days. So a National Hospital Discharge Database, where they're going to talk about diagnoses of people who were admitted and procedures that they had. And we could look over an 11-year span to see how many total hip procedures have been done and how many of those people had a diagnosis of Prader-Willi syndrome. Now you figure there's probably going to be the occasional person with Prader-Willi syndrome who is missed, but probably not that many, because you maximize your reimbursement if you say that somebody's got another diagnosis that goes along with their hip dysplasia or their hip arthritis. So what we found was over that 11-year span, there were 3.1 million total hip replacements that were done across the US, 39 of which were people with Prader-Willi syndrome. Now the interesting point was that the majority of those were younger than 50. So it certainly were people that had a problem that needed to be treated. But again, it's a pretty small number. And actually, if you then play with the numbers, you say, okay, 39 out of 3.1 million, that's about 1 in 80,000. And at its most rare, Prader-Willi syndrome is 1 in 30,000. Well, it still means that people with Prader-Willi syndrome have a 2.5 times lower risk of needing a hip replacement. Okay, now how do you square all that? So we said, well, dysplasia numbers are pretty high, but the arthritis is so low. Why is that? Well, it's because hips remodel. What does that mean? Well, we take this child is 5.5 years old. These hips are not well covered. We don't have the socket coming over the top. We have the socket kind of looking like this. But we watch this child, and here they are 2 years later, and that socket's starting to kind of squeak over a little bit more. And 3 years after that, these are pretty normal looking hips. Now this is atypical. This is not what you see in typically developing kids. Typically developing kids after 4, their sockets are pretty much set. They don't change a whole lot. Prader-Willi syndrome has different rules. So here's another child, 13 months old. Those are pretty awful looking hips. And in a typical child, I would be talking about surgery at some point. But we were able to watch this child. And in fact, most of our x-rays we got because we were treating them for their scoliosis. But here you see also how at 5 years of age, these hips are the sockets nicely come over the ball there. These are hips that don't need anything done for them. So my main point about this is we want to keep on watching these kids. We want to monitor them. So get x-ray when they start sitting. If we find they have hip dysplasia, we follow them up routinely. If we get to a point where that socket's not improving, then we might talk about something surgical. But otherwise, we keep them as active as possible. We try to get as much stimulation across those hips and just see what the hips are going to do for themselves. And in most cases, we're going to do well. All right, now for the meat of the matter, and that is spine deformities. So scoliosis is a side-to-side curve when you're looking at somebody from behind. Most of us have a pretty much straight up and down spine, so any deviation is scoliosis. Kyphosis is the normal curve we all have in our upper back, but if it's a big kyphosis, then we call it a hyperkyphosis. And then lordosis is the curve we all have in our lower back, the small of our back. And again, if that is exaggerated, then it is a hyperlordosis. And you can also sometimes have changes where the kyphosis rides down to the lower back or different things like that. But that gives us a little bit of a vocabulary to work with. So if we look at the numbers, if you look at the articles, it suggests that someplace between 60 and 70% of people with Prader-Willi syndrome will develop some sort of a back curve. And it follows kind of what we call a bimodal age distribution, which means there's kind of 2 age peaks that we see it at. The first age peak is in the very young kids before 4 years of age, and there's a nice little quiet period where they seem to do well, and then we see curves developing again in the adolescent kiddos. And we think that the first peak is really driven by hypotonia, that they don't have the strength to really hold up their back well, and they kind of collapse down. Now, overall, about 15% of kids will need some kind of treatment for their curve, including surgery. And the real concern is that the risk for complication with this kind of surgery in kids with Prader-Willi syndrome is pretty high. It's reported as high as over 50%. So we want to do everything we can to try to manage that and stay away from surgery as long as possible. All right, a few other things that help us with this conversation here is what is our general guidelines for looking at curves. So A curve under 25 degrees, we just watch. If it gets over 25 degrees, we want to start treating it. But what we're looking for is what the curve is going to be when the child is essentially done growing. When they're done growing, you don't have growth accelerating that curve anymore. If the curve is under 40 degrees, 95% of the time, the curve will not get any bigger in adulthood. It's going to stay where it is. If the curve is over 50 degrees, then literature shows us that 95% of the time, the curve is going to get worse. And then there's this kind of gray zone between 40 and 50 degrees where we're very careful to see what happens. So we start talking about surgery when we have a curve that we suspect is going to be greater than 40 or 50 degrees when a child is done growing. And why do we want to treat these curves? Well, it's not just for the cosmetic side of things or how tall they are statutorily, how tall their stature is. It really has more to do with the working of the heart and the lungs. So when you get a big curve, you start to squeeze the lungs. The capacity of your chest gets smaller. And so what I like to say is that the lungs get too squished to get enough oxygen to push oxygen into the lungs. And actually there's also a mismatch because in order for the lungs to work well, you have to have oxygen going in one part of the lung and blood supply in the other part, in the same part of the lung, so that the oxygen can go into the blood. When you start squishing the lungs, then oxygen only goes up in one part and blood only goes to the other part, and they don't meet. And that's where things get dicey. If you have, for a long-standing period of time, the lungs getting squished, well, then the heart is working so hard to push blood into the lungs that you end up getting, the heart first becomes like any muscle, it gets bigger, but then it gets muscle bound, it gets too big, and it starts to fail, and that's something called cor pulmonale. Now, before anybody gets worried, these are things that happen, it takes many, many, many years for this to happen, but it is still the reason for us to treat these curves. So typically we see these issues, the problems with getting enough oxygen into the bloodstream, the problems with the heart, for curves that are over 80 or 90 degrees. But in smaller curves, those are over 60 degrees, you can already, with sensitive testing, you can see, I don't think we'll take that call. Yeah. You can already see that there are changes that are happening. But oftentimes the child is asymptomatic. One of the big problems with Prader-Willi syndrome is that they can have a hidden curve. Now, I've got a couple examples that are older children. This is really a problem for the infants because it's not unusual for me to see a 2 or 3-year-old where they say, you know, my pediatrician always looked at their back, never saw anything that looked like a curve. They were bending them over. They didn't see the asymmetry. And that's because for some reason, kids with Prader-Willi syndrome are able to hide that asymmetry. We'll talk a little bit about that coming up. But for example, this child here, if I look at him and say, okay, you see the creases for his waist? Well, they're a little bit offset, so that's a suggestion of something going on. But look at this curve. He's got a 100-degree curve, and you wouldn't have known that. This child here, one shoulder's a little bit higher than the other, otherwise looks pretty good. Well, he's got a 30-degree curve. So those are the types of things, how they can kind of slip past us and have these big curves, and it's better that we're on the lookout for them early on. So there's always a question about, with Prader-Willi syndrome, does obesity have anything to do with this? Well, studies have shown that the body mass index does not seem to have anything to do with acquisition of a curve, particularly the very young kiddos. And in fact, in the very young kiddos, they oftentimes will manifest a curve even before they go into their hyperphagia or their increase in weight. So we think that the hypotonia is the bigger thing. That if we try to sit them up, they collapse down, and that may be something that that either kickstarts a curve or allows the curve to keep progressing. Now, it's important to keep the obesity under control so that we can detect curves, and if we have to go to bracing, we're able to put a good brace on them, but we don't think that the obesity is actually driving the curve. If we looked at some studies that were done before, this Prader-Willi syndrome study from 2007, it showed us that girls had about a 10% higher chance of getting curves than boys, which is much closer to equal than in the typical population where girls completely outpace boys in terms of getting curves. But if a girl gets a curve or a boy gets a curve, they both have the same risk for that curve getting worse. So gender doesn't seem to play a whole lot into it. In terms of genetics, it seemed that UPD had a higher risk for developing scoliosis, but again, it didn't seem that either UPD or deletion had a higher risk for that curve getting worse. I'm still looking forward to when we get more of our survey data back for these newer registries that are going on, because I think we're going to find some nuances in that data. I'll talk a little bit more about that as we go along. But in terms of treatment, it can be difficult to draw conclusions. There's more and more coming into the literature, but again, it is still kind of slow. We don't know a whole lot. So a lot of what I'm going to talk about now is based on my experience, and hopefully there's something we can pull out of that. The first thing is I want to delay kids in sitting up, because again, they're hypotonic. We all want to get our little baby sitting up, right? That's a fun thing to do. You sit them up and you play with them, but the problem with the child with Prader-Willi syndrome is they collapse down. And they may be able to sit up, but they're using their hands to sit up at the same time. So what I like to do is keep them supported in their sitting position until they are strong enough to pull themselves up to a sitting position. Once they can pull themselves up, then we just let them go at it. But until that time, I want their high chair canted back about 30 degrees so that they can still look around, you can feed them, but I don't like that sit on my lap and just kind of sit there and they collapse down. I want to stay away from that as much as possible. So for example, here's a child who's a year and a half, and you recognize that hypotonic slouch that she's doing, using her hands to support herself, and everything is kind of collapsed in. That's what I want to stay away from. And what I'd rather do, oh, it's a Zoom call. What I'd rather do is have them do tummy time as much as possible. When you get a kiddo on their tummy and they're looking up, they're strengthening all of their extension muscles in their back, and that's the thing I really want to work on. So what else? Okay, so we want to start screening them. When do we screen them? When they're able to sit up. Now, sometimes somebody might identify what looks like a curve earlier than that, and we might get a lying down x-ray, but lying down x-rays, they are unhelpful in two ways. One is that you don't have gravity going across them, so you don't know if there's a curve there or not. The other is that when kids lie down, they don't always lie down the way you want them to, and they may just kind of do this, and you think you got a curve. So I get a little nervous about a lying down or a supine x-ray, but occasionally we just have to do it. We have a kiddo who's a year old who looks like they have a curve and they're not yet sitting up. We have to figure out what's going on there. But typically, once they start sitting, I get x-rays of their spine, same time I get x-rays of their hips. We want to get physical therapy in all kids going as early as possible. And then if we have an infant that's got a curve, particularly after they started sitting, then I start talking about casting. I'll explain a little bit more about that. In the older kids, we go to bracing. And then for the much older kids, we can start talking about surgery type things. So a quick reality check, and that is it's always important that there are some curves that you can do everything you possibly can, and they're still going to progress. It's just the character of the curve. And what I'd like to talk to families about early on is saying, look, if that happens, at least we can feel that we did everything possible versus that we're at the doorstep of surgery and we go, if only we had. So it can be a tough course regardless. But the strategy is to control the curve as long as possible, to stay out of the operating room as long as possible, and to stay away from fusing the spine as long as possible. So one thing, like we talk about physical therapy, we want to work on strengthening the trunk. We want to do sensory integration so they learn how to balance themselves and know where they are in three-dimensional space. And we want to also, in the past I've given this talk with Janice Agarwal, and she likes talking about trying to keep the kids down as long as possible, try to keep them using their arms and their legs for locomotion, for crawling as much as possible. Not always possible, and I'm always happy when I get the kids up and walking and exploring, but there is a good side to crawling, and just to keep that in mind. But again, any activity is good for them. And the important thing is that whereas typical kids get trunk stability first and then strengthen their arms and legs, Prader-Willi kids, again, they follow different rules. Arms and legs get stronger before trunk, and that's where we get that hypotonic sitting. So just to keep that in mind. So again, Janice's favorite thing is hippotherapy. And Alex is now a full-grown kid in his 20s, so she gave me this photo a long time ago. But the nice thing about hippotherapy, it works on head and trunk and leg control, and the kids don't see it as therapy, they see it as playtime. And I really don't have any restriction on what age you can start. It's interesting that It seems like every ranch has its own set of rules, but I've had kids who start hippotherapy at 2 years of age, and I got other places say, oh, they can't do it until I can't remember 5 or 6. So whatever age you can start at is perfectly fine by me as long as it's a safe program. Hippotherapy. Oh, that's this thing on horses. So I will take questions at the end. If I don't have time for questions, I'll take them out in the hallway. But yeah, so hippotherapy, if you ever heard of the hippodrome, or actually a hippopotamus, it's actually a horse of the Mesopotamia. So hippo means horse. I know, it sounds like they're actually walking around on a big animal. But so yeah, the movement of the horse encourages the kids to exercise, and it also helps them sit up, because you're kind of crooked, you're going to fall off the horse. So you have to kind of control yourself. And if you have a good therapist, they can actually guide exercises to try to work both sides of the back. Or if the kid is already starting to develop a curve, try to strengthen the side that the curve is going to. And then we get to the kiddo with a bigger curve, over 25 degrees or sometimes over 20 degrees in an infant. Then we start talking about casting. So casting, I like to say, is kind of an old technique that's come back. 30, 40 years ago, we used to cast older children before we did their spine surgery, before we had hooks and rods that we could put into the back. And then it kind of fell away for a while, and then somebody by the name of Min Mehta came up with the idea of casting infants for the scoliosis. The thing about casting is that you can make a curve smaller with casting. You cannot make a curve smaller in most cases, and I'm going to come back to that. In most cases, you cannot make a curve smaller by bracing, but you can with casting. So it's effective. We used to say, oh, we're only going to cast kids, actually only cast them to 3 years of age. Now I say, I want to start casting before 3 years of age, and I can cast them up until sometimes 7 years of age. And in some cases, it's to get the curve down and hopefully cure it. In other cases, it's just to manage the curve so we can let the kiddos get older before we do anything surgical for them. So we have to do this under anesthesia for the most part, and that's probably the hard part. Under 2 years of age, we change the cast every 2 months. Between 2 and 3 years of age, we change the cast every 3 months. And when they're over 3 years of age, we change it every 4 months. And if I have somebody who I need to actually cast for years, which occasionally will happen, then I'll also look for some time this summer that I can give them 4, 6, 8 weeks of a cast-free holiday where we put them in a brace, we let them go out and swim in swimming pools, but we just keep the casting going. And we end casting when either we've reached our goal of getting the curve small enough that we can transition out of the cast, or we plateau, we're not getting any better, we say, okay, we're just going to go to a brace, or we know from the start that we have to do surgery on the child, and we're just trying to nurse them along until they get old enough. So this is a schematic of what a casting table looks like. So we have what's called head halter traction. It's something that fits underneath the jaw and the back of the head there. We pull some traction on that, and we have some traction also at their pelvis to try to stretch them out. And it's a special table where we can wrap all the way around them circumferentially. And one of the things that we're trying to do is not only push the spine from side to side, but we're also trying to untwist the spine. So one of the interesting things about scoliosis is that you get a rotation of your spinal column. So if my fists are the vertebrae from the front, and my forearms are the ribs, then what happens with the scoliosis is this. You get a kind of a twisting of the spine, so these ribs get pushed backwards, and these ribs get pushed forwards. And actually, if you look in the front, you'll also see there's a little deviation of the chest there as well. And that's why the common thing that we do to look for if somebody's got scoliosis, we have them bend forward and looking to see if we see asymmetry in what their back looks like, and that's because there is that rotation of the spine that's pushing some of the ribs upwards. Now, that's also probably one of the reasons why we underdiagnose scoliosis in kids with Prader-Willi syndrome, because they don't seem to get as much rotation for the amount of curvature that they get. That's kind of an aside. But what we're looking to do when we cast them is take that asymmetry and straighten that out at the same time we're pushing from side to side. So it looks something like this. We've got the kid on the table. Here we're wrapping the plaster around the body. Here we're pushing it from side to side and untwisting it. And then we make some cutouts, and we make it look fancy, and we end up with both the baby and the doll with the cast on. but that's kind of what the cast looks like. So we looked at a 10, 11-year span of kiddos that we had casted for Prader-Willi syndrome. We had 34 kids that had more than 2 years of follow-up. And what we said is we would start casting them when the curve was over 25 degrees and they were ready sitting. So if they weren't sitting yet, we'd treat them in a brace until they're getting up and sitting. And as an aside, we've had plenty of kiddos who were not walking before they went to a cast and learned to walk in the cast. So it's not that it becomes an anchor and they can't do anything. They are actually very motivated to get up and around. And we ended up with kind of 3 endpoints. The cured endpoint is where we get the curve under 20 degrees, hopefully under 15 degrees when we took off a cast. Those kiddos we put into a brace for a year, and then after a year we would maybe stop the brace altogether or only brace them at nighttime. Then there's the brace kiddos. These are kiddos that we could not get the curve to get down to the cured range, but we got it down substantially. We could go to a brace, and we kept on monitoring them with the expectancy that years in the future we'd probably have to do something surgical for them. And then there was the controlled kids, those that we knew from the start had a curve so big that at some point we're going to do surgery, but we're hoping to push that years in the future. So we ended up with, first of all, the average age that we started casting kids was 32 months of age, but as old as 5 years of age to start the casting, as young as 14 months. Average number of casts was 8, but it could be as few as 3, it could be as many as 18. And then the average follow-up was more than 4 years, almost 5 years there. So 1/3 of the group were cured. That means 1/3 of the group, we got down small enough, we could put them into a brace, and a year later, we got them out of the brace for a period of time. And they start off with curves that were on average 44 degrees, and we got them down to 17 degrees. And it took about 6 casts. About half the group were the braced group. And so they started off with curves about 55 degrees. We got them down to about 35 degrees, so that's a good improvement, not nearly in the cured category, but good enough that we could then go into a brace and keep monitoring there. And then we had 4 patients who were in the controlled group that they started off on average with a curve of 85 degrees. In fact, 2 of them were at curves over 100 degrees. And what we're looking to do is just delay surgery as much as possible. And on average, we delayed surgery about 4 years, which is pretty good. Another quick thing to point out. So you see in the cured group, we had 7 kids with UPD and 5 kids with deletion. So more UPDs than deletion. Well, that is kind of the backwards of what the typical population is. When you get to the brace group, it's a little bit more typical where we have 10 with deletion, 7 with UPD. In the control group, 3 deletion and 1 with UPD. And so my thought from that is probably deletion kiddos have more of a problem with the younger scoliosis than the UPDs do. But we need more research to kind of back that up. But here's a timeline, for example, in the kiddo who was cured. As a year and a half of age, a 36-degree curve, which would ordinarily set off warning signs for all of us. In his first cast, we can get that curve down to 10 degrees. Out of a cast, after 4 casts, he had about a 14-degree curve, so we put him into a brace. And this brace was at, hang on a second, can't remember how old he was. I think it was a little less than a year and a half of casting altogether. Here he is at 4 years of age, and so it looks pretty nice in terms of his curve. The problem is we have to watch what keeps on happening. So 4 years later, he's getting a little bit of a curve. A year after that, he hits 25 degrees, we start bracing him. 2 years after that, he's got a 30-degree curve. But mind you, we had several years that we had no bracing, no nothing, that we're just following. So I think we improved his quality of life. The end result may still be they need to have surgery for this, but we've delayed it a lot. We let him do a lot of growing, and he's also got a nice symmetrical looking chest here, where both sides of the chest look very similar. So it's a new technique, and we just have to keep watching these kiddos. Now, here's the other side of it. Here's a controlled curve. This is an 18-month-old child who had a 106-degree curve when we started. In our first cast, we made that curve about half the size. And then we were able to kind of keep controlling it there. So out of cast, our curve was about 60 degrees. And what I want to draw your attention when I'm talking about symmetry of the chest, if you look this lung over here compared to that lung over there, well, look how much different it is over here. This lung is very, very narrow and very stretched out. And this one is kind of on the fat side. And both of those are not well-functioning lungs. Whereas here we've kind of restored what the lungs should look like. And that's what we want to do, is allow them to keep growing, try to normalize that chest space. And here she is at 4 years of age, 13 casts, 6 years of age, 18 casts, and this is where we said, okay, now's a good time to go into surgery. Now, actually, the fun thing about this is at 5 years, I said to the parents, hey, we've been doing this now for more than 3 years. She's old enough now, we can do surgery. And the parents actually said, oh, what's the rush? And here I am thinking, parents just can't wait to get out of these casts. They can't wait to get away from seeing me every 4 months. And these parents were like, no, we actually prefer the idea of getting a little more growth before we go into something surgical. So we couldn't really find any predicting factors, which curves are going to be bad players. So it didn't make a difference if you were a boy or a girl, if the curve was to the right side, to the left side, if the curve was up top or down on the bottom, or at what age we started casting them. The only thing we could find is if we started casting a curve before it hit 50 degrees, we had a 9 times better chance of curing that curve than if it got over 50 degrees. That's the only real thing we could pull out of this. So what it really tells us is, again, screening early is important, keeping an eye on these curves, and starting treatment early if we see a curve that's starting to take off. And I also like to say casting is survivable. When you first see a kiddo in a cast, and it's your child, and you're thinking, what am I going to do with this? It helps know that a lot of other people have gone through this. And I always like this. Here's a 17-month-old. He had a 55-degree curve. 5 casts later, he's got a pretty good-looking spine. And so they sent me this picture here. Having scoliosis is tough, but I am tougher. And he saved all his casts, too, which is remarkable. And here's some other ones that I really think are enjoyable. The kiddo in the middle has actually got a dry suit that they could go swimming with. What about bracing? So bracing is for an older child who's got a curve that's over 20 or 25 degrees that we're trying to slow down. Again, by and large, bracing prevents progression. It does not reverse the size of a curve. And it usually can't make the curve smaller. And it's very important if we can keep these kiddos as thin as possible, because we can fit a brace better too, then we can push on the curve better. So this is kind of what we're looking for to brace with the kiddo on the left there, looking very hypotonic. We put her in the brace. We kind of stretch her out a little bit. We straighten out the curve some. Here's another child, 32-degree curve. Got her in a brace, pushed on that some, and we're able to slow down the progression of that curve. Now, 4 years later, it has gone up into getting close to the surgical range, but at least we're able to slow that down some. But then here are the happy ones. So here's a 5-year-old child, 46-degree curve. Again, that would typically be a big concern. We got her in bracing. Now, my bracing for kiddos with Prader-Willi, under 30 degrees, I put them in only a nighttime brace. What you're doing with the nighttime brace is taking the curve, trying to stretch it out as much as possible in a brace that kind of bends them over. So it's not made for walking. It's very uncomfortable to walk with, but it's comfortable to sleep with, and you're just trying to keep the curve as flexible as possible. If the curve goes over 30 degrees, then I also add in a daytime brace, and that brace is meant to be walked in. It's pushing on the curve to make it as straight as possible, but you can't straighten it out as much as the bending brace. So I like using both kinds of braces. Sometimes get some insurance pushback on that, and we just have to push insurance companies right back again. So here she is. The middle picture is in the daytime brace. Nighttime picture is the nighttime brace. You get that sense of how she's kind of getting pushed over to the side there. And here she is 4 years later with the curve is now only 21 degrees. So she actually had an improvement, which is a very atypical thing. But again, Prader-Willi, different rules. A 10-year-old with curves that were right around 40 degrees, so very much in a concern. And this would be a kiddo that I probably had to talk about the parents of, we're just going to try to get her older and then go to surgery. But we had her in her daytime brace and her nighttime brace. And here she is 3 years later, and the curve is 25 degrees, and I cannot explain this, but don't look a gift horse in the mouth. And then there's the other thing. Remember, we talked about kyphosis and lordosis. So here's a child who had kyphosis in his lower back, and we put him into a brace to try to push on that, and gradually over time, we got a nice correction there. But I also have to say, there is no crystal ball. There are no silver bullets. Here's a 10-year-old curves in the low 30s who I thought, well, this one's going to probably do pretty well with bracing. And in fact, here she is in her daytime brace, her nighttime brace. But I did see a daytime and nighttime brace. But she did continue to progress to the point that we ended up having to do surgery on her. So again, very hard to predict who's going to need what, and that's why I think it's important that we just do everything possible, throw the kitchen sink at them. So what about surgery itself? Well, we try to manage the kids as long as possible, but those curves are going to be over 40 or 50 degrees when they're done growing are the ones that are most likely going to need surgery. And we try to do surgeries as late as possible, but sometimes you have to do something sooner. What do we try to do? Align them as best as possible, not just the side-to-side scoliosis curve that we're also thinking about, but the more important is the posture, the front-to-back curve. And that's not just important in typical kids. So that was a thing that took a while for the orthopedic world to understand is you get a kid who's nice and straight like this, and you turn them, nice and straight like that, and then you turn them to the side, and they also look nice and straight, and isn't this great? And you find out that actually as adults they had a lot of trouble. It's even more so in Prader-Willi, and we'll talk about that in a little bit. But once you get the curve in a good position, then you hold it in place with a couple of rods, one on either side of the spine, and then hooks and wires and screws to hold that, to grab onto the spine to hold in place. Now there is a high complication rate with Prader-Willi syndrome when you do these kinds of procedures. Infection is a big concern, and a lot of that stems from skin picking. So my first kiddo with Prader-Willi, the one in our introduction that we talked about, he actually, I knew about the skin picking thing. I just thought it was kind of a social inconvenience. I told the parents to be, careful of the hands and things like that, but didn't really put a lot of emphasis on it. And they reached out to me about a few weeks after surgery and said, oh yeah, he had picked open his wound, and the wound kept on getting worse and worse. And in the end, he got infected, and we had to take all the hardware out and wait a year and put it back in. So it's a big issue, and nowadays we do a whole lot of things to try to keep them as safe as possible. There are a number of anesthetic things, so the anesthesiologist needs to know how to take care of kids with Prader-Willi syndrome also before they put them to sleep. And then there are the pulmonary issues. So as most of you know, kids with Prader-Willi syndrome can have pulmonary issues. We want them to get a sleep study. I got 5 minutes. Oh boy. We're going to get a sleep study before they have surgery. We have to figure out if they need BiPAP or CPAP. And there's this issue with not having the strong bones that the hardware, the screws can pull out of the bones, that you have to just plan around. So let me talk a little bit about, this is what we used to do for young kids. We'd fuse their spines. Well, that's not a good thing because then you end up with an adult with the chest the size of a 6-month-old. So this is my first kiddo with a 107-degree curve, and this is an expandable implant. So there are 2 sets of rods, 2 come from the top, 2 come from the bottom, and they actually overlap. And the whole idea is that you go in there surgically and you loosen things up and expand them, and you kind of grow the spine out with them. And this is what he looked like when we were done with him. So at 16 years of age, we had gotten the curve to start off over 100 degrees. We got about 50 degrees, and that was a pretty good result. Nowadays, we have something that's nicer. It's called the MAGEC rods, or the magnetically expandable rods. And so this is a 10-year-old boy that we put these into. And what you see here is if you look at these rods here compared to those rods that we've lengthened a couple of times, you see these little areas that you can kind of see through in the rod here. That's actually where we've been able to expand the rod up a little bit. And we don't have to go to the operating room to do that. We do that with this little remote control device here. It's got a big magnet in it. We put it over the rods. That makes a little magnet inside the rod turn, and that makes the spine grow. It's not a panacea. There's a lot of problems with this. It doesn't always lengthen out well, but it has made a big difference for our Prader-Willi kids. All right, so I'm just going to skip through this other than to say, typically when I've done expand these rods as much as possible, I don't do a formal fusion. I'm just going to open up the top and bottom of the incisions. I'm going to take the rods out and put solid rods back in because we can't leave those MAGEC rods in there. Now, what about a spine fusion? Well, this is for curves that are going to be over 50 degrees when a child is done growing. I try to get the children as close to maturity as possible. So if I'm bracing somebody, I say as long as I can keep the curve under 50 degrees in a brace, I don't care what it looks like out of the brace. We just let them get taller, but also more emotionally secure before we take them to the operating room. And so we make it look like that. Take a curve, make it straight as possible, put a rod on each side, hold in place with usually screws these days up and down the spine. I'm going to go through these a little bit quick. These are the before and after pictures, because the last thing I want to hit on is this. This is probably the biggest concern in terms of having a complication with Prader-Willi syndrome, is that, again, they follow different rules, they balance themselves differently. So in typical kids, we like having them stand nice and straight like soldiers. When we're all done, we're all pleased with ourselves. Prader-Willi kids, if you look around at the children you see at the conference, they have a little bit more of a head forward position, and they like that. If we straighten them out too much, they still try to do that, and that's when things get us into trouble. So, for example, this child here, if we drop a line from kind of the top of the neck straight down, it goes just in front of the sacrum. That's where we want it to end up after surgery. And what we want to be careful of is that we take somebody, straighten them out too much, because then they pull away, and they can pull away from their rods. And that can happen at the top or at the bottom. So here the arrow in blue is at the bottom where this person kind of slowly tipped over. This is a child who it happened at the top. They actually came to me from Hawaii, which is kind of cool. But so we had to do a big operation to get her straightened out. Last word about growth hormone. If anybody tells you to stop growth hormone on your child who's got scoliosis, the answer is no, not unless my endocrinologist says to. There's a concern that growth hormone can exaggerate curves, and that's based on Turner syndrome. But in fact, in Turner syndrome, it also doesn't exaggerate the curves. So in short, keep the growth hormone going. Did I make it in time? 1 minute. Okay, then we'll just go real quickly to our, there we go. Okay, so we want the kids to get a pulmonary workup before they go. They want to see ear, nose, and throat. Anesthesia needs to know about Prader-Willi syndrome. There's a lot of resources out there where they can catch up on that too. Want to be aware of food sneaking behaviors. They have a high pain threshold, which can be really good because we get them up walking right after surgery, but it can also be a little bit of a reason why they don't wake up right after surgery. So we tell the anesthesiologist that we don't have to pull the breathing tube out right after surgery. If they're not waking up, just leave it in place, and it comes out later on in the intensive care unit, and that's not a problem. And we want to be careful of the skin picking. They also have a prolonged, what's called an ileus. So after a big surgery, all our guts slow down, sometimes even just stop. In Prader-Willi syndrome, that is extended. The main cause for kiddos to be in the hospital longer after surgery is because of an ileus. So there's a number of things we want to do to kind of help with that. If your child is going to need to have big surgery, reach out. We have a little, or actually, I think PWSA-USA has a primer on their website that we wrote up. But there's resources out there to help everybody who's helping your child. All right, thank you very much.